with all of our, I guess we don't really do subclavian lines anymore, right? But other vascular access insertions, and so we changed the, I told you this, Jack is going to be our first speaker, and I'm going to just let him talk because I need to eat.
Thanks, Deb.
There you go.
Thank you, Deb.
That was terrible.
No. So let me talk sponsorship for a second. What's going on here? I was originally sponsored by BioPatch Ethicon, but I got notice they pulled my travel. So I said, why did you pull my travel? This thing was scheduled since March. Debbie asked me, and they said that there's a thing called the Sunshine Law. I don't know if you ever heard of it, but like all the people that get sponsored, it gets reported to the government, that kind of thing. And J&J gets suspicious if you get too much. So I was getting all the consults. Of all the group of the people, I got 95%. So they said, that's too many, so they pulled my travel. So I'm being kind of sponsored by Spectrum Vascular today. And they're like, used to be Cook, but Cook sold off their vascular line, so it's now Spectrum. So I'll talk about their product just a little bit. I'm going to talk about this today, quality improvement in vascular access. It's about the way we insert the lines and the way the nurse can care for it, a topic that's not spoken about nearly enough, according to me. And let me see if I can get hold on, to do one more thing. Pardon me. Shift tab 5. Capture. Oh. All right, it's doing it. It's recording. Okay. Anyway, so back to the topic. So this organization, the Association of Vascular Access, was founded by Suzanne Herbst. Suzanne Herbst passed away 2 years ago. It was a sad day for all of us. Her story was she was in San Francisco in the late 80s at the height of the AIDS epidemic. And she was taking care of a lot of AIDS patients, and they had vascular access to treat their infections. And whenever they developed a fever, the doctor would order the line to be removed. And Suzanne realized, well, that wasn't helping very much, because pretty soon you ran out of vascular access. So Suzanne realized that vascular access had to be improved. You see all the vendors and the stuff that's in the hall, that wasn't there in the 80s. And really, Suzanne was a catalyst for all that. And 7 years ago, I was lucky enough to be a recipient of the Suzanne Herbst Award, as was Nancy Moreau a few years before me. And it was like one of the highlights of my professional career. Most of you weren't there. This is Suzanne giving me the Herbst Award. It's going to be a long day if that doesn't work.
You want me to get Bill?
I'm giving you this container for your ashes.
Do I have to use it today? That was anyway. That was Suzanne handing me the Herbst Award in 2018. Huh?
Handing you the urn.
Handing me the urn. Do me a favor, Nancy. Just jiggle that, because I'm going to have to stand here because my thing's not working here. All right, so these are my disclosures. I do speaking for the following companies, so I have certainly some bias in there. This is the AVA bias slide. You know, like, when you're biased, it doesn't mean you got it wrong. It means you're biased. Okay, so you declare it. You declare it. It's one way to deal with it. You know, I am a biased speaker. You know, so what's the goal in all this, the way I see it? We're trying to standardize practice at the highest level because we work on human beings. Has anybody heard about standardizing practice, lean principles? Like, we're not learning medicine anymore. We're learning systems analysis, Boeing, the airline industry, Toyota manufacturing, but all these things, they add to what we're doing, right? But what, you know, so you hear about this standardizing practice. And Rob Dawson kind of taught me this, like, what do you get out of it? What do you get out of standardizing practice? It can eliminate unnecessary variation. So in other words, if we're all approaching the problem the same way, we should have similar outcomes. Whereas if we all approach it differently, we're going to have different outcomes, right? So the problem, as I see it, is that these devices are put in poorly. And I'm going to show some clips. Earlier this year, I was at a hospital I considered the world epicenter of venous depletion because they had intravenous heroin in the community for over a century. So the doctors there really had to deal with, you know, people that didn't have veins, and they came up with some creative solutions. But I'm going to play some clips from that institution, right? So basically, do we want a dressing that requires frequent changing or one that stays intact for 7 days? You know, and it's going to be a little interactive today. You guys are going to interact with me whether you like it or not. And, you know, this might be the most important thing that the inserter does to prevent infections. Put the line in the way that the dressing will stay on for 7 days, right? So the problem as I see it is that these central venous access devices are inserted suboptimally. The dressings aren't staying intact. And the never event, you know, CLABSI was designated a never event. It happened 250,000 times last year. Does that sound like never to you? I mean, like, it doesn't quite sound like to me. And like, so are these facts related? At some level, I'm sure they are related. So, show of hands, has anybody seen anything like this? All right, who doesn't like it? Like, listen, people, we're the vascular access community. We shouldn't be seeing stuff like this. It's wrong. You know what I mean? Like, the fact that we're teaching this to the next generation is just really sad, you know? So according to me, the state of acute vascular access in the United States is deplorable. And, you know, to me, this is what incipient CLABSI looks like. In other words, I don't need a positive blood culture to tell me this isn't good for the patient, you know? But, you know, the thing is, if you found something like this, what would you do with it? Is there anybody's door you can knock on? Hey, Dr. Smith, have you seen bed 6 in ICU? It's a real mess down there. There's no place you can go with it, and you can't leave it. So we're really stuck once somebody does something like this, you know? But according to me, somebody has to be in charge of vascular access, especially if you want to make some changes, you know? But there's something wrong. There's something wrong that this stuff is being tolerated, right? So what can you infer? Like if I look at this dressing, what can you infer about the inserter? He needs remediation, right? What about the trainer? What can you infer about the person that trained him? Shouldn't be training people, you know what I mean? Like, and then like, suppose the ICU director comes in Monday morning and finds this, right? It's not on him, he didn't do it, right? But if he goes home Monday afternoon and leaves it, it is on him. So like, do you think they should fix something like this or leave it? You think there's any literature on that? You ever try to convince a doctor without a paper? Show me the paper. Show me the paper. You know what I mean? Like, you know, it's crazy, right? So I was in a hospital 2 years ago. I was in a hospital for 3 months to deal with their CLABSI problem. The chief medical officer told me that heads were going to roll if they didn't get CLABSI under control. And what I came to realize was he meant his head was going to roll if they didn't get it. So he was really invested, you know what I mean, in this kind of thing. So after I was in this hospital about 6 weeks, I'm rounding in the ICU with decision makers. And that's the key. You know, you can round with the vascular access nurses and with the infection prevention, and they're great, and they see the story. But until you get somebody that can make a payment or get, you know what I mean, like you're really stuck. So I'm rounding with the chief medical officer, the chief of the ICU, and we found this, right? So like, I'm pitching a fit, but I'm being nice, you know? But let me go on the record and say that, you see this central line dressing on the earlobe? If I need my central line dressing attached to my earlobe, I want that person to do it. Look at that. It's like, look how it's, that's what a central line earlobe dressing is supposed to look like, you know? But, you know, I'm pitching a fit, like you can't do this, you know? But 2 days later, after my fit, it was still intact. So I'm saying to myself, look, what do I have to do? You know what I mean? So I was down in the coffee shop with my son, and the chief of the ICU was walking by, and I called him over for a little conversation that went like this.
Hey, Dr. Blake.
Yes.
You know that patient we saw 2 days ago with the central line dressing attached to the patient's earlobe?
Yes.
That line is still in place. And it kind of indicates to me that the leadership of the ICU was willing to tolerate the poor quality of care.
And by the leadership of the ICU, do you mean me?
So let me say that didn't exactly work out for me. You know what I mean? You can't tell somebody directly to their face they're willing to tolerate a poor quality of care. I mean, it hurts them to their soul. But I mean, like, if it's legit, I mean, we're a little stuck. I mean, if nobody's willing to tolerate, if they're willing to tolerate a poor quality care, nobody's in charge. So on one hand, we're in trouble, but on the other hand, there's a place where you can deal with it. But I have to learn. I can't do that. I have to go. I have to learn as well. I can't do that anymore. So, but you can't fix the problem if nobody accepts response. It's not just going to magically get better. All right. So today, I want to explain that. There's exactly one way to improve your outcomes. There's only one way. You have to improve your process. That's how this works. Today, I'm going to be talking about process more than outcomes, right? And the great Takashi Osada put it like this. If the process is right, the results will take care of themselves. So you know how many hospitals I go to with, oh, we don't have a CLABSI problem? And then you go looking around and it's nothing but a mess. You know what I mean? Like, so something's got to give, All right. So I've tried to elucidate the problem. These lines are being put in poorly. The dressings aren't staying intact. What is the solution to this, right? So how do you prevent a disruption or prevent an infection? Number one, you have to insert the catheter properly. Numbers 2, 3, 4, and 5 are the same thing. Like, there's just no way around this. Like, the greatest nursing care in the world, that's not how it works. It doesn't substitute for a poorly inserted catheter. I'm sorry, right? The exit site is crucial and is permanent. So you know that bundle we do, washing our hands and draping the patient? It's very important, but it's temporary. That helps you prevent infection during the procedure. But the exit site has a permanent effect on the life of that line. And I like to use antimicrobial catheters, and I think there's good evidence for their use. So the way I look at this or deal with this thing is what I call the life cycle of a central venous catheter, with the goal of standardizing practice, standardizing what we're doing at each phase of this. The model for this, so the 5 phases are the assessment phase, pre-insertion, what you know is the insertion bundle, the actual insertion of the device, the dressing, care, and maintenance phase, and the removal. Anything good or anything bad happens in one or more of these phases because that's all there is and that's all there'll ever be. Another way to look at this is the chain of CLABSI prevention, and the chain is only as strong as its links. So let me see where I go. All right. The model for this is phase 2, the insertion bundle. The insertion bundle is evidence-based and standardized around the world. In other words, what you're doing here in Maine is what I'm doing in Baltimore, is what they're doing in Sydney, Australia. Evidence-based at the high, practice at the highest level around the world. That's our model. We have to do that for the other phases. In other words, we have to assess the patient in standard fashion and come up with like the proper line or maybe a selection of lines. But you can't just say, you have to have a standard way to assess the patient. I'm not going to, so basically for the assessment phase, have a good reason for the line. TPN, hemodialysis, multiple access in a critically ill patient. There are reasons to do it. I'm not going to spend time on the assessment because I could, because of time considerations, Moving on from the assessment phase, which is vital, and we have to standardize what we're doing, we come to the pre-insertion, right? This phase was originally described by the CDC and the Institute for Healthcare Improvement and validated by the Keystone Report, Dr. Peter Pronovost, Johns Hopkins, the lead author in 2006, right? This phase lasts from the time you do your hand hygiene until you drape the patient, the pre-insertion phase. So it consists of these 5 things: hand hygiene, cleansing the skin prep, maximum barrier precaution, daily review, and avoid the femoral site. Now, young lady, if you're an OCD note taker, be my guest. We will send you the PDF of this. We'll send you videos of this. But if you want to take notes, please be my guest. Now, I was asked by the, I usually say by the HICPAC committee in Washington to rewrite the insertion bundle. I made that up, right? But in my rewrite, I took out daily review of necessity. Why? It's not an insertion practice. It's a care and maintenance practice. It involves, in phase 4, the care and maintenance. But when they did this stuff in 2006, they didn't know where insertion stopped and care and maintenance started, right? So I removed that. The other change I made was instead of avoid the femoral site, it's avoid the groin. The femoral vein goes from the groin to the knee. So if you get it down outside the groin, the middle of the thigh is good, the lower thigh is good. It's just the groin that's the problem. Now, this thing, this bundle was credited with a 5-fold decrease in the CLABSI rate in 2006. It takes 90 seconds to do it. I'm sorry, I'm here to tell you there's much more to vascular access than these 90 seconds, right? But, you know, if people want to believe that you get a 5-fold decrease, you know, go ahead and believe it. I personally do not believe it. During today's talk, and I may go over a few minutes, I'm going to cover 5 procedures. Number 1 is like the way I did that, I slipped that in. All right, so this is Matthew Ostroff, one of the greats, you know, advanced nurse practitioner in New Jersey, and this is what a mid-thigh femoral looks like, and this is how you do the procedure. So that mark, I'm about 14 centimeters below the groin crease.
I'm just gonna come out. Yeah.
So do you think that procedure would be a benefit to the patients in your institution? So we have to learn how to do it. We can't just be like, hey, that's great, and like there's evidence supporting it and not do it because that's pretty irrational. I think this is a major advance in the care of the patients. And like they've shown that, you know, you really get, you know, you get a very low infection rate, a very low thrombosis rate if you do this thing as opposed to the groin, you know. So where are we? And I'll have to stay grounded. We're moving into phase 3, the actual insertion of the device. So my motto for this phase is insert the catheter properly. And it's ridiculous. Is this thing working? Is this, all right. It's ridiculous that you have to say that in 2025, but you do, right? This phase, the actual insertion of the device, lasts from the time you drape the patient until you put on that dressing. When I put in a line in intensive care and slap on that dressing, by definition, the patient is now in the care and maintenance phase, right? So what we're trying to do in this phase is figure out what are the best practices and then do the best practices. Again, like standardize our practice. Just like phase 2, the insertion bundle's standardized. So this one has to be standardized as well. All right. There are 5 phases to this in the Ladun framework. These 4 account for 1% of the line. And the dressing and care and maintenance accounts for 99% of the line. So like, if you were going to affect your infection rate, would you deal with the little orange sliver or the big blue pie? The action's clearly in the big blue pie, but they're related. This is my message, that the nurse, these things are nursing tools. CVCs are nursing tools. And like the doctors have to realize, once we put that line in, it's just starting, it's over for us, and it's just starting for the patient and for the nurse, right? So I talk about a proper insertion. What am I talking about? These things. Number 1, minimal attempts, hopefully 1. Number 2, we want the tip close to the cavo-atrial junction. So let me tell you, in this room, that's nothing new. Everybody believes that. There's a counter-narrative to our colleagues in the emergency department, anesthesia, and critical care. They don't believe it. And they've got papers. They've got literature. So there is a, you know, there is a narrative on this, right? We want a proper exit site. And let me summarize it for you. The chest is good and the ear is bad. We don't want an exit site by the ear. Quote me, when you leave here, when you walk out that door, it's going to be, boy, that guy was saying a lot of stuff. This is it. The ear is a bad place for addressing and the chest is a good place, right? We want to use sutureless securement, antimicrobial protection, and we want the dressing to stay on for 7 days without support by adhesive tape. You know, like I was listening to Matt Gibson lecture to critical care nurses, and they're going, "Oh, we're not allowed to use tape." Like, you're the ones that do the care and maintenance. Like, you don't know you're not allowed to use tape. Now, I understand if the dressing's not staying on, you got to do something. I get that, but we'll get into that. So, phase 3, the actual insertion, I say there are 16 decisions or choices, and these are my recommendations. So what I mean by that is, if you decide you want to cut the skin, you made a choice. If you decide you don't want to use a nice Echo News ultrasound, you made a choice, right? People, they're going to have 16 of these choices. So I'm going to try to help you standardize it at the highest level. But you know, you're going to have these choices whether you recognize them or not. And these are the 16. Now I have lectures where I go through the 16 and make the doctors vote on what and they always vote on 15 or 16 as, you know, being standard. We're not going to do that today, but I'm going to show them in the different videos and the different procedures. Decision number 1 is ultrasound always. I got a great ultrasound slide with Tchaikovsky playing. It's super, but I'm saving time, so I'm not going to show that. But decision number 1 is ultrasound always, right? Decision number 2. That's the internal jugular vein. For those of you who haven't been doing your radical neck dissections lately, right? You know, so what's the issue with the jugular vein, right? Like if I walk through your intensive care department, I guarantee I'd see some jugular vein action. You know what I mean? Like, what's it ever done to me? What's the problem with the jugular vein? Like, there's too many ways to do it poorly. It's not standardized. You know what I mean? It's not put in standard fashion where you're eliminating unnecessary variation. For example, you can put it high in the neck. And I was looking at this thing like, where's the gel pad? Is it on the patient's eye? That's the thing that's holding the endotracheal tube, is it? It looks to me like it's going to be on the patient. Like, who would do that to a person? You know what I mean? Like anyway, you can put it in the middle of the neck and you can put it low in the neck. Vascular access experts from Maine, where do you want the exit? Yeah. Any place else is not standardized at the highest level, right? So like Ledun principle number 1 is we want it low in the neck, and I consider this to be mandatory. I mean, you can put that pad on the guy's eye, you know, go ahead, right? All right, so here I am at the world epicenter of venous depletion in my hometown earlier this year, Harlem Hospital in Manhattan, right?
Dr. Ledun, principle number 1 for the internal jugular vein is low in the neck, and I consider that to be mandatory. If we're going to standardize this at the highest level.
That's interesting because I was never taught like that. I was always told high. I was always told to go high, but it's scared of the human. Exactly. Yeah, well, you get more.
I hope to get it before ultrasound.
Before ultrasound. Alright, we used to put it high, but because we were scared of pneumothorax.
Class is a bigger, badder infection than pneumothorax will ever be. Okay.
The whole lecture went like that. I didn't know who was presenting, me or them. You know what I mean? Like they wouldn't shut up. You know, but what do MDs do or not do? I want to make a point that if you keep asking why, like if you see a crummy insertion, you keep asking why. Oh, they were trained that way. Why were they trained that way? You keep asking why. It comes down to they're scared of pneumothorax. So what do MDs do or not do if avoiding pneumothorax is their guiding principle? They won't use the chest site, what they call subclavian vein, which is the axillary vein. They'll utilize the internal jugular vein exclusively, and they'll go high in the neck. So all that fear of pneumothorax leads to crummy practice. So I want to talk today about the catheter and dressing as a unit. I think this is a big deal, right? See, the catheter has to exit from the dressing. I have my solventum lady. So here's a catheter. It can exit from the dressing like this, like this, like this. Like it can come out, but the catheter has to exit from the dressing or the nurse can't use it. You can't just coil it up, you know, like a snake and do it. So here's a typical internal jugular vein catheter, right? And the catheter can exit from the dressing like I just showed, north or south, east or west, right? So like, let's say that you have the catheter exiting from the east side of the dressing. You know, you might get a little configuration like this. And like, so here we have somebody that was smart enough to get into medical school and graduate from medical school and stupid enough to put the dressing on the widely described as the dirtiest part of a human being. Like, hey, I'm sorry, this is not how you prevent infection, right? Or you can have the catheter exit from the west side of the dressing, and you might get a nice little configuration like this, you know. And my buddy Shelley DeVries, the infection preventionist, they're like, you know, you can touch the hub. Not good, you know, like, so they didn't use the other part of the dressing. They didn't use the pants, you know, part of the dressing, right? The classic is the doctor goes to the head of the bed, and in the classic is the doctor goes to the head of the bed and directs the catheter up north. And it gets this little configuration, which my son affectionately calls the mess on the neck, right? And like, what's all that adhesive tape doing for the patient, you know? Or you can have it exit from the south side of the dressing. So again, you know, what's the goal? Standardizing practice at the highest level. We have to you know, we can't do whatever you want, right? So vascular access experts, which configuration standardizes practice at the best level? Yeah, yes. Anything else? If you any other way, and you can do it the other ways, it's not standardized at the highest level. What are the doctors going to tell me when I present this to them? What are they going to tell me why it shouldn't be done? It'll kink. Exactly. And like, this is my favorite thing. When somebody tells me something, that somebody that doesn't do the procedure tells me who's done it 7,000 times, what's going to happen? Like, yeah, oh, well, I'm waiting for my first kink. Yeah, no, you put them in properly, they don't kink. Exactly, 100%, you know? So principle number 2 is to rotate it down, and I consider this to be mandatory. So principle number 1 is low in the neck and rotate it down. So what do you get? You get the dressing primarily on the chest and not up by the ear, right? And this is what I'm talking about.
Hold this thing down toward the chest, not up near the ear. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest where it belongs. We're going to put it on with the slit facing the catheter, and we're going to offset it up just a small amount, maybe about 10 degrees. Let the catheter. All right, we're going to do the skin prep. Okay, so we're going to take off the rest of it.
Standardizing practice at the highest level, right? So like, I was rounding in a medical school in my town, you know, and I found this. You know, I was with the chief of the intensive care unit. I'm like, I'm having a seizure. You know what I mean? So they gave me a little Dilantin and I calmed down. You know what I mean? Like, but like, you know, I called Lisa Gorski, the lead author of the Infusion Therapy Standards, and she called me and she goes, you know, her point is like, yeah, we changed the dressing. We know, reflex, you got to change the dressing. And Lisa said, Jack, you have to ask, why is the dressing disrupted, right? So I've given you the tools. I've given you the answer. Why is that dressing disrupted? It's facing north. Yes, yeah. This is the interaction. This is the kind of thing that we look for. Right. It exits north. Gravity grabs the tails and pulls it toward the floor. In the patient I just showed, the tails are coming out the bottom of the dressing and gravity's working with you. It has to be done this way if you think an intact dressing is important for the patient. All right, moving on. Second procedure, the internal jugular vein. 56 years ago, an English physician named Ian English described the technique for jugular vein cannulation. But in 2025, we don't have to do it his way. There's been a lot of changes over the years, right? So a year after English wrote his paper, Jernigan from Kentucky wrote his paper, coming from the side of the bed, low in the neck, right? But look what Jernigan did with the catheter after he got it in 1970. So, but like, looking at it, my technique looks pretty similar to Jernigan's technique. You know what I mean? Low in the bed. But look what they did with the catheter after they got it in. They drained, you know, so in 1970, I give them a pass for this, but I wouldn't give them a pass for it in 2025, right? They didn't know you could do it like this, right? All right, so I was brought into the Mount Sinai Hospital in New York City by the great Jonah Kaparis. Jonah is an interesting, great person, a good friend of mine, kind of like Debbie. She runs the New York thing, and Jonah's famous for midline vancomycin. She wrote the paper on midline vancomycin, and like a lot of people don't like it, but she had her data and she presented her data. She brought me into her hospital to see what was going on there, right? So basically, this paper is basically talking about what I'm talking about, quality improvement in vascular access, right? And their analysis at the famous medical school said that CLABSIs were most frequently associated with internal jugular vein access. All right, I buy it, right? Now they're going to tell you why they used it. So if I was writing this paper, I'd be telling you why I did something different. But their data showed that the jugular vein causes the most infections. Now they're going to tell you why they had to use it, right? Their reasons for choosing the internal jugular vein were, number one, their patients are sick. Let me go on the record. At the height of the epidemic in April 2020, they were on the nightly news every night, and the patients looked dreadfully ill. They're no sicker than your patients. You know what I mean? And I don't give patients that are sick a procedure that has an increased risk of infection. I don't buy the logic there. I give them the procedure with the least chance of infection. Their second reason for choosing the internal jugular vein is that they're training residents. And I always ask the audience, if anybody has a weapon, end my life now. I don't want to live. If you're going to teach people an inferior technique because they're residents, like they're doomed to do it that way the rest of their lives. I mean, this insults me. I mean, I have a big experience training residents, and they learn to do it my way. I don't dumb it down to them because they're residents, you know. And the third reason they use the jugular vein is the subclavian, in quotes, isn't easy. And they're right. It isn't easy until you learn how to do it. And then it becomes pretty easy, Keegan. You know what I mean? Like before you learn how to, you know what I mean? Like, you know, you learn how to do it, and nothing's easy until you learn how to do it. Quote me on that, Jack LaDunn, MD, right? All right, so I'm at the famous institution, and I'm going in to see a procedure. The patient's got C. diff, and they wanted to put him on TPN, right? And they have a beautiful line room right in the ICU. And the beauty of their line room is it's staffed by an OR tech. Imagine what the line room would look like if it was doctors. You know what I mean? They had an OR tech to keep it clean and give you stuff, right? So I'm on my way in to watch the procedure. And I said to them, oh, by the way, I've got my video camera with me. I know you're not going to let me use it. Yeah, sure, go ahead, you know. So now what do we have here? We have somebody from outside the institution with an unstable personality and a video camera. Like, you know, what could go wrong here, you know? So I'm going to show you the procedure. And famous medical school, right? How not to do an internal jugular vein procedure, right? They start at the head of the bed. Where's the dressing going to be when the doctor starts at the head of the bed? Going to be down, north. It's going to be by the ear, right? They did use ultrasound. Otherwise, this could have been E in English in 1959 or 1960. They have to learn to use micropuncture equipment. This is ridiculous. It's the middle of the neck. This is not how we teach internal jugular vein procedures. Passes the J-wire. Look at the ear with the tape. I don't want to see the ear. Ear is bad, right? So he removes the needle. And I thought he was going to dilate without cutting the skin. But no, yeah, and it warmed my heart. But he made a nice little nick, no big deal. I don't do it. But, you know, the skin is a natural barrier to infection, right? All right, let's suture it down nice and tight. Let's violate every principle that we can here, you know? Like, let's move the ear out of the way to get the dressing. This is bothering me, you know? Heparin, I don't use heparin. Heparin last night stimulates biofilm growth. Huh? So now, all right. What's wrong with the dressing? It's going west and it's near the ear. Yeah, no, like these are the principles. These are principles, like we got to standardize it. We got to put it low in the neck, rotate it, if we're going to use the jugular vein, right? So you guys are great, you know. All right. So this is how I like to do the jugular vein. Again, low in the neck, rotate it down. I come from the side of the bed. It's the only way I do it. It's the only way I teach it. If you can do it from the head of the bed, like Tim is always up my behind about doing it from the head of the bed, fine. So I don't consider that mandatory. Do you do it from the side of the bed? You do it? Okay.
We're going to puncture the vein as low down.
You can see the benefits of the side of the bed. Micropuncture equipment, like in the PIC kits. My needle going through the carotid sheath, that's that line into the jugular vein. You got to use the micropuncture stuff.
Now we'll see that we're nice and low in the neck, we're not in the middle. We're going to put the 5 French micro introducer over the
This thing's not working.
wire. We're not going to cut the skin. The skin is the barrier to infection. This feels like it's going to move. The inner cannula and the wire. They'll put a finger over the hole.
It's amazing how little bleeding you get when you don't cut the skin.
Now, I'm going to dilate with the 7 French dilator. Okay, it's going to feel a little bit of pushing now. Okay, so we're going through that. Okay, there. That I'm going to put in the 7 French triple lumen catheter. Going in smoothly. We're going to put this into about 19 to 20 centimeters because the nursing step. Nurse, where would you rather care for this catheter, in the neck or in the chest?
One enlightened nurse. Standardize at the highest level. This is how you do it. You can do it 10 other ways, but I mean, this is the way we standardize it, right? So the low internal jugular vein, like they're scared of pneumothorax. Like, you know, listen to me. Fear is irrational. Go to see your psychologist. You know what I mean? But like, it's not fear. It's risk and benefits. The procedure, like, I'm not scared of this procedure. It has certain risks. So what's the risk? Proximity to the lung and probably increased chance of pneumothorax, right? What's the benefit? The dressing will stay intact, and you'll have a lower CLABSI rate. To me, the benefit far outweighs the risk. So the question of they're always throwing up, anybody ever hear a doctor invoke pneumothorax as the reason for why they do stuff, right? But like, I want the question to be, what can we do to prevent pneumothorax and maintain an intact dressing, right? To me, like, don't stop at pneumothorax, but we want to have an intact dressing because that's what helps prevent infection, right? You learn to follow your needle through the tissue. If you can do this, you can go as low as you want. You're not going to get pneumothorax. If you can follow your needle down, you're not going to get a pneumothorax, right? So, and if you can't do it, you probably shouldn't be doing this. But the point is that following the needle is a technical solution to pneumothorax. It's in our hands. What you do can prevent pneumothorax. That's not true for CLABSI. But what happens after a line is inserted? It's given to an RN to use and manage. CVCs are nursing tools, right?
So before we start, nurse, I could put this catheter in his neck or in his chest. Where do you prefer to care for it? The catheter exits from the chest or exits from the neck?
From the chest,
Why?
because it's easier, usually the dressing will lie flat.
Thank you.
What I like about that video is the inserter asked the teammate, the nurse, where does she want it? She only owns it for 99% of its life. I think what the nurse has to say is more important than almost anything else, right? But in contradistinction to the internal jugular vein, the ultrasound-guided axillary vein is standardized at the highest level. And I'll get in. So because of the real estate, all of the axillary veins will look like this or have the potential to look like this. You know the thing about, this, people see this? Where's the other end of that catheter? It's in the heart. You know, people lose track. Like, you know, who wants some mess like this? You know. So let me just. I didn't put up my anatomy slides. The basilic vein ascends in the arm. When the brachial vein joins it, it forms the axillary vein. The axillary vein ascends in the deltopectoral groove, and when it gets to the lateral border of the first rib, it changes its name to the subclavian vein. You can't see it with ultrasound. You can't see the infraclavicular vein with ultrasound very well, and you can't puncture it. You can see the axillary vein all day long. So when using the axillary vein, when using ultrasound, you're puncturing the axillary vein. The doctors refuse to learn that point. But back to the epicenter, the world epicenter of venous depletion.
Between those ones on the left side and these nice optimal ones on the right side, what is in between? And this is kind of getting to the heart of these little side conversations, right? So knowledge. I mean, if somebody doesn't know you can do it this way, there's no way you can
I want
achieve
the
it. Right?
subclavian, though. Are you putting back, are you putting subclavians back in?
Yes, well, stick with me, okay, a little bit. Hey, I think this is what you were telling me. Well, we've always done it this way, right?
We used to the whole guy. We
Training,
used the subclavians.
like, what happened,
Are we back to
fear
subclavian?
of what?
Are we back to subclavian? The chief of surgery is asking me if we're back to subclavians. I didn't know we left. What do you mean? What do you mean we're back to subclavians? You know, like, you know, but what does it tell you if the chief of surgery is asking this question? It tells me that this institution and many others is not teaching this technique, and it hurts my soul. I mean, this is my go-to line in intensive care, unless they have kidney disease, right? So I asked, what percentage of critical care fellowships are teaching this technique? A fellow at the Cleveland Clinic told me less than 10%. The chief of critical care in Orlando told me less than 5%. I don't know, but I mean, I think it's bothersome, you know? But what's the chance that an inserter learns this technique after his training? So he's been trained by people that are scared of pneumothorax. You know, like, it's not gonna happen. So if you don't learn this in your training, so it's slowly being extinguished in the country, you know? All right, so there are many things we disagree about in the field of vascular access, but we agree about this. The optimal location for the dressing is the chest, right? And our friends came up with this, you know, upper neck is red zone, bad. It's like the Darcy-Dolman for the, you know, medications, red, green, yellow. You know, the upper neck is bad. If you have to put it above the clavicle, we want it low in the neck and supraclavicular, and certainly the green infraclavicular area is the best. Why? Has less motion, it's flat. You know, it has the best chance for dressing to stay intact, right? The famous French intensivist Jean-Francois Timsit wrote an editorial in 2002 and asked the question, is the subclavian vein the royal root? It's an 8-page editorial. Timsit didn't answer his question, but I will. It is. It is. I mean, this is where central lines, we're trying to standardize practice at the highest level. This is where it goes. Why? I mean, the dressing will stay intact, lowest chance of infection. What's the evidentiary basis for the axillary vein, what the doctors call subclavian? CDC, this is the Shea guidelines from 2022, and this is the Society of French Intensivists, and Jean Timsit is the lead author there, right? All right, so extra credit question. I'm not going to deduct if you get this one wrong. So it's vascular access history. Who wrote the paper that first described percutaneous central line insertion? I'm not going to deduct. Okay. It was a French military surgeon, Robert Aubagnac, describing his technique in the World War II, right? And this is Aubagnac's procedure.
Chest looks like a better site to me, although she's got subcutaneous emphysema, which will preclude the ultrasound visualization of her axillary vessels. You can see
Gas in the sub-Q, you can't, precludes the ultrasound transmission.
this is the one situation where blind sticking is better than ultrasound guided. It's more simple at it. So there we have the subclavian venipuncture blind. We try to insert the J-wire.
Now, I came up doing that procedure. I love that procedure, but I won't do it. Since I learned ultrasound, I won't do it. But you know, like when you connect with a vein and you get blood, you get a little hit of dopamine. when you do it? Is it something like this? Like, imagine you do an 18 gauge needle.
Go in. Oh, yeah.
You know, I have a physiologic response, you know what I mean, when I hit the vein there, you know what I mean? All right, so moving on to the third procedure. That dashed line is the deltopectoral groove. The axillary vein lives in the deltopectoral groove. Micropuncture equipment, EKG-based tip location.
We're going to be puncturing our axillary vein inside of the humeral head in the deltopectoral groove. I'll tell you to be quiet, okay? Give a nice skin wheel on the way out. That staying, ma'am? Yeah. Give me a sec. Hit it, Tina.
There's my needle in the axillary vein. The artery's to the left and the pleura is below.
You have good flow? Then we push down on it. We just get it to go into 20 centimeters. So we're going to maintain a little back action.
Skin is the natural barrier to infection. I don't believe in cutting it or suturing.
We're right in the deltopectoral groove, right where we marked it. We're doing a medical procedure here. But when you pay your bill, whoa, lady, whoa. Hey.
I had a swatter.
So we're going to put on the securement device.
I didn't swatter.
And we're going to get it, the hub. All right, good. So here we have an ultrasound-guided right axillary puncture. The dressing's in the right place. Turn your head to the side. We're giving it to the nurse in proper position where she can provide proper care and maintenance. We did not incise the skin. We did not suture it down. And the hub is not old.
So the ultrasound-guided axillary vein, like, there's no fear. There's risks and benefits to this procedure. You know, forget the fear thing. So what's the risk? Pneumothorax, you know, you're near the lung. What's the benefit? The dressing will stay intact, decreased chance of eclampsia. Again, to me, the benefit far outweighs the risk, you know? So what can we do to prevent pneumothorax and maintain an intact dressing? You got to learn how to follow your needle. I don't know if this qualifies as Nancy's 3 stages of the needle. It's 2 stages anyway. But there's my needle in the, axillary vein. And if you can do that, if you can follow your needle through the tissue, you're not going to get pneumothorax, right? And following the needle is a technical trick. Like, in other words, I can prevent this thing by a technical thing, by what I'm doing. CLABSI's different. There's no technical solution to CLABSI. It's a process, right? All right, let me talk about EKG-based tip location. You guys all know it's not a new topic. You guys, who's using EKG-based tip location in the room? Almost everybody. Great, good, okay. So now this part is be more directed toward doctors, but some toward you guys, right? So chest X-ray versus ECG, right? ECG is clinically better. Why? You can tell during the procedure, and you can make you move to fix it while you're sterile. I mean, like, all right. It's cheaper than a chest X-ray. No radiation, and your RNs are using it. Like, in other words, give me a reason why you're not using it in your institution, right? So why aren't MDs using it, right? So here's the deal. The SA node is thought to be at the junction of the superior vena cava and the right atrium, right? I've been in the heart surgery, and fellows going, oh yeah, there's the SA node. You know, I don't think anybody's ever seen it with their eyes, you know what I mean? But that's where it's thought to be. So you get the Einthoven triangle with the lead. So the sensor in lead 2 is down here on the upper thigh. It's about 25 centimeters away from the heart. The heart is the electrical generator that generates, this cool stuff over here, right? So suppose the electrode, instead of being on the thigh, you put the electrode at the cavoatrial junction. You get the P wave becomes a monster. So it's larger than the QRS, and the atrial musculature is much less than the ventricular. But because the sensor's right there, you get something like this. Focus on the P wave changes.
We're going to talk about EKG guidance of the catheter. So I estimate from the left axillary position that he's going to be about 28 centimeters down to the cavoatrial junction. We're we're gonna remove the inner cannula and the wire. Now we're gonna insert our catheter with the guide wire. It's gonna attach the alligator clip to the wire that's inside the catheter. We're at about 21 centimeters. We see a prominent P wave. I'm into 23 centimeters, and you can see the P wave enlarging. So we know that we're heading down toward the SA.
That's navigation.
26 centimeters, we see an even larger P. Then we go to 27. At 27, we see the first appearance of the deep negative spike. So 26, we had a very large P wave. At 27, we had a very large negative spike. At 28, the spike becomes even larger, the negative spike. Now we're at 29. Now we see a change. The P wave is not as large as it was at 29 centimeters. It's still a negative spike. We're going to pull back out to the 27, which coincide with our measurement. 27 centimeters to the SA node, and we're going to get the chest X-ray in this position.
All right. So most nurses are trained to find the negative dip and then pull back till the negative dip goes away. Is that right? Is that your training? Okay. Now, I just want to make a point, ask a question. What's the excursion of the catheter going from supine to upright? It's 2 to 4 centimeters. So when I'm putting it in the supine position, I want to see the negative deflection, knowing that it's going to come up by 2 to 4 centimeters. That's just how I practice. All right. So you can use that. That was using a wire as a conductor. Does anybody use saline as a conductor for their thing? Okay. So I'll show.
We're going to put the J wire.
I'm just going to forget. You guys know the wire. This is using saline as the electrical conductor. Works very nicely. You can use it with any catheter. It's not like proprietary to a particular catheter.
Okay, somehow they'll take me doing the dressing. Nice and easy. Give the catheter a flush. Good.
All right.
Our attention to the internal ECG on the machine.
And this is what it looks like there. Similar just to the wire, just a different way. And you can use, it's pretty inexpensive, right? So why don't, I mean, this to me, I thought that I would be able to deal with this in the country, but I've not been able to. I can't get in their attention. So why don't information? So critical care and nephrology told me they never heard of it. And then you think, like, who reads the vascular access literature? We do. They don't read this stuff. If they saw an article on this, they would just go past it. They wouldn't get it, right? Some people told me, oh, yeah, we used that in the 90s. I'm going, so, And then, cardiac anesthesia and the EG tell me it's too cumbersome. I won't even get into that. This guy does he intubates the patient, floats a Swan-Ganz, puts a central line, does an arterial line, but clicking up the thing into the machine is too cumbersome, All right, I'll go into this a little bit. So, this concept, cost effectiveness? Everybody knows cost effectiveness, but try to explain cost effectiveness. It's not so easy. Anyway, this is a healthcare economist from Australia, right? So basically, on the x-axis is the clinical effectiveness. So it goes from here, this is getting better, right? On the y-axis is cost. So you get these 4 quadrants. In the left upper quadrant, you'll get something that doesn't work as well but costs more. If somebody comes to you with that argument, don't buy that one, right? In the left lower quadrant, they'll come to something that doesn't work as well but you save some money. Usually we don't go in that direction. The right upper quadrant is where we usually live. Somebody's going to come to you with the greatest thing, but you got to pay more for it. Then you need supply chain, purchasing to help you decide. In the right lower quadrant is something that's more effective and you save money. It's rare, but it happens. When somebody comes to me with this, and I believe it, I don't stop till I get it because it's irrational. The EKG versus chest X-ray comes down here. It's better and it's cheaper than the EKG. All right, let me talk about antimicrobial CVCs for a few minutes. So basically the CDC came up with a 1A recommendation to use an antimicrobial CVC in adults when it's expected to be in more than 5 days. And these are some of the recommendations for that. The minocycline rifampin catheter, highly cost effective, like a lot of studies showing it, proved better anti-infective capability than some other catheters. And it has, I say again, a 1A recommendation. Here's a forest plot showing that all of the studies come down on the good side of the line, and the total comes down on the good side of the line. And that was versus chlorhexidine-coated catheters. And again, here's showing the chlorhexidine versus the minocycline rifampin catheter. At MD Anderson, they do something interesting. Like they do wire exchanges for catheter infections, and they have records showing that it works really pretty well. It's not been adopted throughout the country. Most people will remove an acute central venous catheter, but they do wire exchange. So, are they telling me I'm done? All right, kill that light. And then, so one of the arguments. Did you hit the wrong button, young lady? All right. So one of the arguments against the antibiotic-coated catheters is bacterial resistance, but they've studied it and it does not have any resistance. All right, moving on. I probably have another 10 minutes and I'll be out. All right. So, vascular access experts, what's a good reason to use the internal jugular vein? In fact, the reason. Why would you pick the internal jugular vein? Yes, next time you do this lecture, right? Like patients with chronic, same reason we don't give them PICCs. We use the jugular vein when they have chronic kidney disease because we don't want to ruin their real estate for grafts and fistulas, right? What's a bad reason to use the internal jugular vein? Let me answer that. Patient with you're out of your mind if you put in a percutaneous internal jugular vein catheter in this patient, So if they have chronic kidney disease, we want to use the jugular vein. If they have a trach, we don't want to use the internal jugular vein. So what's the solution to this? One solution is to put in a tunnel internal jugular vein. So in other words, you're using the right vein, and then you get the exit site where you want it, right? All right, so this patient, I'm going to incise the skin because I'm going to make a tunnel. So I use a 5 1/4 inch 14 gauge angiocath for my tunneling device. The tunneling is not the skill part of the procedure. The skill part is puncturing the vein and getting the tip in the right location, right? So we're going to pay attention to EKG tip location, gum mastic, liquid adhesive. All right. And this used to be, tunnel catheters used to be surgeons in the OR, interventional radiology. Now it's RNs at the bedside. This is RNs at the bedside in skilled nursing facilities. It blows my mind. They're putting in tunneled HD catheters in RNs in nursing facilities. It's amazing. It's really like where we've gone with this, right? And this is how you do the procedure. Side of the bed, low in the neck. You want to go in about 9 o'clock from the right side. Micropuncture equipment. That's my tunneling device. I don't know what you would use this thing for. It's a 5 1/4 inch IV cannula. Yeah, it's great for that. But I mean, it's an IV cannula. The rest of this is a PICC insertion.
Remove the peel away. The catheter in, we remove the peel away. We have to aim deeper, so this is telling us we're at the exact right spot, at the cable-atrial junction.
This is a permanent securement device. Subcutaneous anchoring system.
Go in, and now I'm going to release and deploy.
So the wings go underneath the skin. It works really pretty well.
Like this, and we're going to put the top on.
You don't have to change it with each dressing. It's permanent securement. Whereas the adhesives are supposed to be changed,
Good on this side.
whether they are or not.
Last thing we have to where the dressing is going to go. permit that to dry for 30 seconds. It's gonna go right here. Feel the way it goes down, sticks down very nicely, dressing. So this is what I consider to be modern vascular access. Thank you.
So I used to ask, does that look like it's preventing an infection? But I changed that to, does it look like it'll stay on for 7 days? Once it stays on for 7 days, I kind of did my job. Moving on to the last procedure, the acute hemodialysis catheters. So like, if I came to your hospital, I could tell you which catheter has the worst infection record. Pretty arrogant, because I've never been to your hospital, but it's the same all over. It's the same, the acute hemodialysis catheters, right? And you know the never event, CLABSI, the never event? I've never seen a dressing stay intact for a dialysis catheter when they're directed up toward the ear. I've never seen it. You know what I mean? And this is Mackey's work showing that this. All right, so I'm lecturing in this hospital in New Jersey, and the chief of surgery interrupted me. So for me, like, I like interrupting people. I don't like getting interrupted. No, that's not true, but it's the chief of surgery.
Yes, sir.
I was just going to ask, why do you think the HD catheters have the highest? I don't want to say it's because the people that put them in do it wrong and everyone else does it better. Is it the access? Is it the patient?
There's a whole bunch of reasons for it. One of them is, like, this catheter here. This is lipstick on a pig, as far as I'm concerned. This can't be put in the way it's put in like this, and it's folded down so it doesn't wind up in your auditory canal. No dressing with this catheter has ever stayed intact. So it's almost like you're defeated by the equipment. They're heavy catheters. All the facts. The patients are sick.
All right, so I'm going to show, this is my last procedure. I'm working with a resident and he's doing some. We're coming from the side of the bed, low in the neck, rotating it downward. We're not going to incise the skin. The patient has an endotracheal tube, a short neck, a beard, respiratory failure, acute kidney injury, and we're going to put in this catheter.
Look at the probe. Hit the center of the probe, Christopher. Hit the center of the probe. I'll tell you when to look at the screen. You look at the probe.
There's my needle in the jugular vein, very close to the carotid artery.
Slowly.
Micropuncture equipment. Standardizing practice at the highest level.
I do not want to cut the skin of this man with an INR of 3.9. 4. Okay, now because it's been dilated once, we should be able to get this approach. I'll put a little traction on the wire. Okay, that's 20. So teaching point is, in a patient like this with a short neck, on a ventilator with an endotracheal tube, we do not want a dressing up near the mandible, the hairline, or the ear. We want it down on the chest. Nurse, where do you want the dressing this patient, on the neck or on the chest? Why? Because it lies better and you can provide proper care and maintenance?
Yeah.
Did I put words in your mouth?
Yeah.
And the dressing is going to have a good chance to stay on for the 7 days.
Sorry, you're okay, sir.
You're okay.
It's almost over.
Relax.
Okay, and I can feel the dressing going on. Very nice, very in a sticky position. So we're going to retract all this. Good.
Is that what dialysis catheters look like in your institution? Why not? It's 2000, when? It's 2025. This is standardized at the highest level. You know, oh, it's gonna kink. No, it doesn't kink. All right, so let me summarize this thing. Suppose there was a study that showed the outcomes from this were the same as the outcomes from this. Wouldn't you do it this way anyway? Then you don't really need that study. Fear of pneumothorax is not a good reason to make a mess on the neck, really. You know, that's psychopathy. Go see your psychologist if you have fear, you know. Can you track the needle? If you can track the needle, you're not going to get pneumothorax. Like this procedure, like it's never worked. It's never worked. We're teaching people to do procedures that have never worked. That dressing's never stayed intact. I mean, what could be sillier than teaching somebody, you know, these guys are smart. These critical care guys, they're smart. We're teaching them to do procedures that doesn't have a chance of working. I mean, if you want improved outcomes, there's a way to do it. These are my recommendations. You know how many hospitals you go to, like CLABSI, they try to fix CLABSI by fixing care and maintenance? Every hospital, they always try. My favorite is when they switch from one chlorhexidine-containing dressing to a different chlorhexidine-containing dressing. That might be the answer. You know what I mean? Like, why don't we try putting the catheters in properly? But you have to fix insertion first. Why? It happens first, right? The exit site, the securement, and the dressing, these things have a permanent effect on the outcome. I like to use antimicrobial catheters and EKG-based tip location. Care and maintenance is 99%. It depends on the way we insert the catheters, right? Hey, I want to thank you for your attention. It was early in the morning. You guys were great. Thanks for the interactivity. I'm happy to answer a question or two. I'm sure I went over my time, but go ahead. And I'll be around for another session or two. But if anybody has a question in public or while I'm breaking down, I'm happy to answer. All right. See you around. So you're gonna set up a computer, or is it? All right. What time is it? Doesn't matter. I got my phone right there.
That was excellent.
Oh, thanks. I know I went. I know.
Really, really